Thank you. 1.5 years ago, I've promised myself that I start every public talk with a public denunciation of the war. And I think that should be especially emphasized in a group of pediatric oncologists and hematologists who are constantly dealing with saving just one's and putting all the resources into saving one's kid's life. And during that moment, a huge number of kids being killed and wounded in Ukraine. So saying no to war, I'm for sure saying no to any war, and especially no to children death. I will start with a basic kind of basic thing. I would like to bring attention to the fact that the current theory of LCH pathogenesis is being based on a fact that the mutation that goes, it can be anywhere in MEK-ERK pathway, but most likely it is BRAF V600T mutation, is being detected in a stem cell. And the more system the disease is, the more systemic, the earlier precursor is being is carrying the mutation. However, further studies show that it's not just about the level, but about the quantity of mutated precursors. So once again, we're having the disease. So the disease is located in the bone marrow, and this is, I think, important for our future discussion. So the current standard and the current kind of conventional treatment is vinblastine plus prednisone as a first line, optionally vincristine, cytarabine, and prednisone as a second line, and for high-risk LCH, especially for LCH4 protocol, that was the amendment was for cytarabine and cladribine in doses 500 milligrams 2 times per day and 9 milligrams 1 time per day, respectively. So, which is really high. But during the last several years, we've seen a huge increase in interest of targeted treatment in such patients, and the first big paper which brought to the discussion this topic was the comprehensive analysis from Jean Donadieu, but I think that the whole, not just Europe, but many countries had their input in this study. And what we've observed is that targeted therapy is being very effective, especially in a critically ill group of patients. And so I think that every LCH specialist who had a chance to deal with targeted therapy in LCH was amazed with the efficacy of this treatment, and it cannot be compared to any conventional treatment. However, at some point, we've realized that any attempt to stop targeted treatment, especially in risk organs plus patients, would result in very fast deterioration of the condition and the relapse, full-scale relapse. So several years ago, we were at the point where we had very effective treatment with targeted therapy, vemurafenib or dabrafenib, for patients with BRAF V600T mutation, which was effective, but only during the treatment itself. It wasn't curative at all. And then we had highly toxic combination of cytarabine and cladribine, which was also effective, but sometimes the complications, especially infectious complications, were very severe, and this resulted in toxic deaths. Also, there was no conventional treatment for the patient who failed the third line. There were no conventional treatment for patient relapsed without risk organs who relapsed a third or fourth time. So we had two different schemes, which were both good, but both had some cons, and this was very kind of stalemate at that point. I also wanted to emphasize that during that period, we also had the attempts to lower the doses, and this study was presented by the Argentinian team and showed that lower doses can be also effective, but they are well tolerated. And to be honest, our whole approach, despite using a bit other doses, but was inspired by this particular study. But one can ask why we should even try. For example, if we would take and talk about the United States, so people there, for example, they wouldn't think about stopping targeted therapy and claiming the patients are doing all right during the whole period of the treatment. First of all, we're treating and we're dealing, when we are talking about patients with risk organs lesions, we're talking about very, very small children. So most of them are all around 1 year old or less. And we do not know the effects and the further effects of this treatment in kids. The second thing, sporadically, we're getting here and there some specific cases which would develop secondary resistance to the inhibitors, which is pretty uncommon in LCH and happens in, for example, metastatic melanoma, which is also being treated with BRAF inhibitors. But still, when we are talking about years and years of treatment, we should be aware that things like that, these can happen. Another, and this might be even more important, and this what Jean Donadio's team is investigating in, that at some point, usually after several years of MAPK inhibitor treatment, we can see high incidence of mostly asymptomatic, but sometimes symptomatic CNS lesions in these patients. So as you can see, that from 20 patients, about 80% would develop asymptomatic mostly, but still visible, MRI visible CNS lesions. And this is something we should keep in mind, because I think that talking about more and longer period of time of VEMRAF or other BRAF inhibitor treatment, we should be there that something like that can happen, and we should think how to deal with that. But actually, I would prefer not dealing with that at all and keeping my patients cured. Another thing coming from, and this might be explaining the previous yet unpublished data, is coming from the British team, and they showed that at some point later on, there is a lineage switch with a higher number of T cells with carrying BRAF mutation. And I think this is just the reflection of what's going on in the bone marrow, that earlier precursors are still carrying BRAF mutation, and at some point they can be involved into the process of developing new T cells, and at some point they can finish, so they can finish producing these T cells. And these T cells might be going over blood-brain barrier, for example, or anyway, they can make this secondary lesions. So once again, when the patient is taking the drug, the disease is just being controlled. It is not being cured. We've tried some combinations, different ones, with a very, very limited success. But that was, for us, indeed a success, because these were heavily pretreated patients. Most of them were after salvage therapy with cytarabine and cladribine. And we tried also to implement lower doses, but we were successful only in 1 out of 5 cases. But that was a bit scarce evidence, and we decided that we need the study on the potential possibility of the combination. So we've enrolled the first patient in 2018, so that's 5 years ago already. So we have some perspective on that. So the general idea, I think, is understandable. The general idea is to get the best parts from chemotherapy, so to cure the disease, and to get the best part from the inhibitor, keeping the patient stable, safe, and without any clinical signs and symptoms. So we've enrolled all patients with verified risk organs lesions or at any line of therapy, or second or further relapses in risk organs minus cohort. BRAF positivity was obligatory. We've carefully evaluated the patients regarding their QT interval elongation or documented heart diseases, and informed consent sign as a must. And we wanted to, so the primary endpoint was to assess overall response rate proportion at vemurafenib cessation. From current perspective, that might be a bit foolish, because it would be obviously very high, closer to 100%, and it is 100%. But from 2018, we couldn't know the real response rate. We could only assume it's going to be high. But the real thing which we were interested in is the reactivation of progression-free survival time from therapy start or from vemurafenib cessation, which is even more important. So also we were interested in the proportion of patients with severe adverse effects, and overall survival obviously was our endpoint. So this is the scheme of the protocol. So we start with 28 days induction of vemurafenib. Then we continued with 3 courses of cytarabine and cladribine. The doses are on the left. So cytarabine is 100 milligrams per square meter, 2 times per day, every 12 hours. And cladribine 6 milligrams per square meter once a day. So we did 3 courses like that. We stopped vemurafenib during these courses. And then we started vemurafenib the next day the course ends. And we, after the last vemurafenib, we conducted the assessment and continued with 3 courses of monocladribine, which was supposed to be maintenance therapy. And I will talk a little bit more about these MRD points, but to mention, after the last monocladribine, we wouldn't proceed with any other treatment at all. So that was the stop. And then we measured the outcomes without any additional interventions. So not just this is kind of a new scheme, but this is, I think, one of the shortest ever applied for treatment of risk organs lesions in LCH. So MRD, this is a bit tricky term. I wouldn't call this MRD because we are not making any clinical decision based on that. But we've implemented cell-free DNA analysis from peripheral blood, and bone marrow aspiration and selected, sorted CD34 plus, CD117 plus population. And we analyze this with the help of ddPCR, which is digital droplet PCR, which is very, very precise in and can detect such small amounts of mutated DNA as well, both in peripheral blood and in this selected population. So in the paper, you could see 19 patients. Here's a little update, and during the Histocyte Society meeting, there would be another update from the 5 year perspective, which would include, I think, 30 patients, if I'm not wrong. So we focus on mostly on risk organs patients, which were very young, younger than patients in risk organs minus cohort, especially at the start of the protocol, because these patients would undergo more lines of chemo. And as you see, most of the patients were during their first or second line. So significant amount of patients would fail their first line of treatment. And another thing I want to emphasize, that risk organs patients were severely ill at the beginning of the therapy. So usually we would admit these patients in a very, very severe condition: trilinear cytopenia, hepatosplenomegaly, hyperfibrinogenemia, so like full-scaled LCH as we know it. So not surprisingly, during the first 28 days of vemurafenib, we would see a dramatic improvement of the patient status. This is very, very, very obvious for BRAF inhibitors. The patients would improve drastically straight away. And this was also reflected biologically by the decrease in allelic load dynamic. So the cell-free DNA would decrease, drastically decrease. And you can see that it stays pretty low during the whole treatment. And however, you can here see the only patient who relapsed with risk organs. This is quite visible here. But to state straight away, we do not have enough patients for now to talk about the predictive levels of cell-free DNA or of allelic load in myeloid precursors. That's too early, because even surprisingly for us, this was a very effective treatment, and that's hard to say properly, but we need more relapses to say what levels we would expect to be predictive. So, but another interesting point is that you can see the fluctuations of the cell-free DNA even after the treatment was finished. So I will talk about it a little bit later, but this is a very interesting fact that even after 6 months, for example, after full stop of the treatment, the patient would have some low levels of cell-free DNA BRAF V600T load. So here are the load characteristics. You can see that the initial load was much higher in patients with risk organs, which would reflect the biological nature of the disease, the general disease amount, as well as for myeloid precursors. But you can see that still the patient, despite they have median 0 level, they would still have some very small amounts, which would also reflect the general systemicity of risk organs minus disease, despite not involving risk organs directly. But also at the moment of vemurafenib cessation, the patients were more or less equal, which was kind of encouraging, because we would achieve our aim to decrease the load, to kill the precursors, and this is visible here. The main slide, I think, you would be interested in. So as you see, from the current perspective, we have 80% of risk of relapse-free probability, with a median follow-up of 22 months. But I think currently that should be even higher. And there's 88% in RO minus group with one relapse happening, with a median follow-up of 25 months. Once again, I think this is also very important to address. Most of the relapses happen during the first year, I would say, but the median time is 3 months, which is close to the median time of relapse in Jean Donadio's paper, but it was 1 month, which is also explainable by the fact that we used maintenance treatment for these patients, and this is from vemurafenib cessation. Toxicity, and this is also, I think, an important point, because we haven't seen any vemurafenib associated toxicity grade 2 or more. The mean period of neutropenia was about 8 days, which is 3 times lower than in classical doses. And once again, this was previous Jean study with higher doses of cytarabine and cladribine. And there, the median time of neutropenia was about 23 or 24 days. We had some skin rash, both for vemurafenib and for cytarabine, QT correlated elongation, cytarabine fever and febrile neutropenia happened in 22% of cases, but no confirmed septic episode was there. So we've never received any positive hemoculture from the blood, which is also, I think, a very, very good result, especially looking at the higher toxicity profile of higher doses. One very important case we have is the secondary MDS in risk organs minus patient. This is the patient after 2 relapses. He was risk organs negative, who developed, after 1 year, who developed neutropenia, thrombocytopenia, and had 7q minus in 80% of cells. Interestingly, NGS was positive for heterozygous CHAC2 mutation. And currently, I think he still awaits, he's doing pretty well, he waits for the typing and for the decision of HSCT. To give you some background, the mean percentage of secondary MDS in patients after 2 CDA is about from 2 to 5%. So I think having one case of that is well, kind of, is a warning, but I think that is still getting into this basket, and probably it fits the general understanding of 2 CDA toxicity. This is a complicated slide with myeloid precursors load, and once again, it's too early to say anything about the value of this method, but we can see that the patient with the highest load in the myeloid precursors develop risk organs positive relapse, when the other patients with 0 levels develop only risk organs. So the relapse was in other sites, in bones and in the skin. And this is also very interesting because we decided to put these patients who relapsed back on vemo and also evaluate their levels of BRAF loads in blood and in bone marrow. And when it was negative, we decided to once again get them off. And we were successful in 2 cases. So these 2 patients, despite their proven relapses, were 6 and 12 months on VAMO, and then we stopped VAMO, and they're living without the need to take VAMO already for 12 and 27 months respectively. It's now, I think, even more. So this is also, I think, a very important point. So somehow this is possible to cure the local relapses only with targeted therapy. And this is a question to be discussed, why? And if we can use that for example, risk organs negative patients, and on what conditions. So the combination is kind of safe, I would say. And I think it's enough to cease vemurafenib therapy without a relapse. And myeloid precursors may predict the risk of relapse better than cell-free DNA load. But I think further studies should be conducted to prove that. And there are some open questions I would like to. Do I have 1 minute just yet? Right?
Yes, you have.
Good. Just to address you and maybe to discuss after that during the Q&A session. So what helps to achieve the curative effect of this combination? Because we've seen high doses sometimes not be able to cure the disease, or even reduce intensity conditioning or myeloid ablative conditioning during HSCT also sometimes result in relapses. This is quite interesting point because the doses are lower. And the second question is there a synergy between BRAF inhibitors and chemotherapy? And if we can use that for our own good, maybe we can go even for lower doses safely because there is some kind of a synergy. We decided to pause vemurafenib during the chemo, but our idea was to limit the interactions. But maybe we should, vice versa, we should use that during this time, and that would bring some additional effect. What's the prognostic value of cell-free DNA or cell-fraction ddPCR? That's also a good question because we can expand that to the bigger population and use it as real MRD because we're only naming that but not using that. Does one size fits all? So does it? I mean, can we use the same scheme for patients with CNS lesions, for sclerosing cholangitis, for, I don't know, third relapse? Or maybe we can adjust the scheme if we have an idea behind this regimen. And can we use the same scheme for other MAPK inhibitors? Can we use that in patients, in BRAF negative patients? These questions, in my perfect world, all of them would be separate studies, but we're living in the world we're living in. So for now, we can only theoretically address them, or maybe design something, at least smaller study, to check it. So I would like to thank the team I was working with. I used to work with in Moscow, and they're, I think, getting on track pretty well, and we're in contact, and they're doing pretty well. And especially I would like to thank our patients' families for their trust, and all these patients were in the protocol, and they're doing happily. Thank you very much. And